Somatization disorder is the topic for this video. And soma or somatic refers to the body, and what we're really talking about is more of a psychiatric disorder. It kind of is a very difficult to diagnose and very difficult to treat disorder that really is quite troublesome to the patient. I'll give an initial summary before I get into it. It's basically a situation where a patient has multiple complaints, so multiple somatic complaints. And the important thing to remember is, unlike other psychiatric problems, these are not intentionally produced. The patient is not trying to fake or trying to do this intentionally for some ulterior motive. They're not feigned, they're not intentionally produced. There's no secondary gain that they're trying. They really feel that these complaints are real. So that's a very important part. So a typical scenario is you'll have a young person, usually 30 years of age, or around 30 years of age, and he or she will have quite a few complaints. And there's a certain basic criteria. There has to be at least 4 body parts, 2 or more GI symptoms, and I'll talk about the symptoms a little bit later. At least 1 reproductive symptom, reproductive or sexual symptom, and 1 neurologic symptom. Now, I don't know if physicians actually sit there with a chart and actually match the symptoms that the patient tells them with this chart, or this criteria, but that's what the textbooks say. So you'll have a patient that comes in and has multiple complaints, and the important thing, the very important thing, is that the tests, the diagnostic tests that are done, are all normal. So that is a very typical scenario of somatization disorder. You'll have a young person that comes in multiple times to multiple doctors, has a set criteria of symptoms, and the doctors will do all sorts of tests. I mean, you name the test. I mean, X-ray, CT, blood tests, you name it, right? A long list of other tests, perhaps hysteroscopy, colonoscopy, and they're all normal. So then how do you treat it? And that's the great challenge. So that was a brief introduction, so let's get into the symptoms. Well, I just touched on this, that you have to have 2 or greater GI symptoms, at least 1 reproductive, and 1 neurologic. And they could be anything. I mean, long list of things. For GI, they had nausea, vomiting, abdominal pain. For reproductive, they could be dysmenorrhea. They could be dyspareunia, which is pain during sexual intercourse. Neurologic could involve things such as headache, fainting, and things like that. It could be really anything. Other things that accompany the symptoms are a level of stress and anxiety that the patient will have associated with these symptoms. And also, the patient can also have comorbid psychiatric conditions such as depression and perhaps other psychiatric conditions as well. And right along the lines of symptoms and history, the patient is usually what they call a doctor shopper, where they hop from one physician to another. You know, what's known as doctor shopping. And this is another telltale sign of somatization disorder. And of course, another part of their history is multiple testing. So, and they may even carry those copies of those tests with them when they go to see another doctor, or if possible, if a doctor can pull up their previous tests, maybe it was done in the same hospital or same computer system, they can see that, oh, this patient's already had all these tests done and they were all normal. Multiple testings and they were all normal. So how do you diagnose this? How do you actually come to the conclusion that this patient has indeed somatization disorder? Well, it's basically just a clinical criteria based on the symptoms that I mentioned before. And also, it's really a historical analysis of the patient. You have all these symptoms, and they're obviously causing tremendous distress in the patient's life. And the patient has really had a lot of tests, but they're all normal. And the patient, you can clearly tell, is not trying to fake them, not faking them. And there's no gain that they're trying to receive, like, Munchausen's or malingering and those other types of similar psychiatric disorders. I personally think it's a bit difficult, it's a bit challenging, there's a lot of subjectiveness, there's a subjective nature to this, but that's really how you diagnose it. So how do you treat it? Well, obviously there's no medication, right? There's really nothing wrong with the patient in terms of physical conditions. Obviously there is some psychiatric element to it, so sometimes they recommend pharmacologic treatment for the psychiatric disorder, like, for example, maybe the person's depressed, so you put them on an antidepressant. But the one thing that has been shown to really help with this is regular appointments with a primary care physician. So what you say is, okay, let's see you, let's say once every 3 weeks or once every 4 weeks on a regular basis. And what this does, it allows the patient to have a supportive, trusting relationship with the doctor, who can see them regularly and coordinate their health care, offer symptomatic relief, perhaps even treat their comorbid psychiatric problem such as depression or anxiety, and of course avoid unnecessary tests. And this is really the key to the treatment. So I wanted to show 2 clinical vignettes that kind of go through this. A psychiatrist on consult team is asked to see a 32-year-old woman for depression. She was admitted to the hospital for workup of nausea, vomiting, abdominal pain. After doing multiple tests, including abdominal X-ray, CT of abdomen, the medical team has found no reason for these symptoms. In talking to the patient, the psychiatrist learns that she has had many medical problems over the past 10 years and has been in the hospital more than 10 times. She reports having excessive menstrual bleeding and a miscarriage, as well as difficulty becoming aroused during sexual intercourse. She cannot tolerate high-fiber foods and has heartburn and bloating. 2 years ago she had a lump in her throat, had difficulty swallowing, Nothing was found. Past couple of years, she has had frequent migraines, blurred vision, has seen several neurologists. She also hurt her back and now has chronic back pain. Which of the following is most likely diagnosis? Well, I don't know if a doctor will ever do this, but let's just see if they have that criteria: 2 or more GI symptoms. Well, you have nausea, vomiting, abdominal pain, so they have that. At least one reproductive symptom. I think the menstrual bleeding would probably fall under that category, and so will this problem with being aroused during sexual intercourse. And then one neurologic symptom, migraines, and then she's also seen a neurologist too. So the criteria is there. The next thing that's part of somatization disorder is the need or the history that involves multiple testing, and that's definitely there. And no reason's been found, so they're all normal. So this is a classic example of somatization disorder for the reasons described. And one more clinical vignette. A 30-year-old woman has history of, since adolescence, of multiple vague physical complaints, including headaches, nausea, bloating, abdominal pain, dysmenorrhea, fatigue, fainting, dysuria. She is now being seen in a physician's office where she describes current abdominal symptoms as the worst imaginable. On physical exam, no abdominal stiffness or masses are noted. Tenderness is elicited, but the site varies and is not reproducible even a minute or two later. On talking with the patient, she does not seem concerned about any specific life events. She leaves the physician with the impression that she may have an underlying personality disorder, possibly borderline or antisocial. Which of the following is most likely diagnosis? Well, this one is similar. Let's see, we have at least two GI symptoms. We got nausea, bloating, abdominal pain. One reproductive symptom, dysmenorrhea would probably be one of those, and one neurologic symptom, and the headache would probably be good enough to characterize that. So this is all there. The physical complaints are vague and they're multiple, and she is young. She's 30 years or younger, and they do talk a little bit about some comorbid psychiatric conditions. It's not really elaborated on, but they do talk about that in the vignette. And this is a very, very classic description of somatization disorder, yet once again. Now I just want to quickly mention that these two are disorders in which the patient is creating the symptoms. They're intentionally producing the symptoms. In malingering, you actually are feigning illness to avoid a specific social or school or work situation. In Munchausen, you are actually mimicking medical conditions intentionally. So that is the difference between those two in somatization disorder.